Good afternoon, everyone. Good afternoon, everyone. Welcome to the Greater Detroit. Welcome to the Greater Detroit Area Health Council and Patient First Medical Clinic MAT and Outpatient Healthcare during COVID presentation. We are pleased to have you join us today. We have a provocative and exciting presentation ahead of us. I am Kate Cohn-Parrott. I am the President and CEO of the Greater Detroit Area Health Council. I'm looking at myself in this little picture here and saying, oh my gosh, it's a good thing that our governor has decided to open salons back because I desperately need a haircut. Even more so, I think I need a manicure, but pretty excited to see that we have some forward positive movement on that. So I am going to present to you just a couple of background slides, giving you a little bit of information about GTECH, who we are and what we do, and then I'm going to turn this over to Dr. Saad and George Long, who are going to really take us through the bulk of the exciting presentation. Nikki's moving our slides for us, so next slide, Nikki. Great. So many of you probably don't know who GTECH is, so we're just going to give you a couple quick slides. There's actually several slides, but I'm not going to spend a lot of time on them. But GTECH is what's known as a Regional Healthcare Improvement Collaborative, or a RIC, and we serve as Southeast Michigan's trusted healthcare convener. Most of our work is done in Prosperity Region 10. Next slide. So this slide actually shows our vision, mission, core values, goals, and strategies. I will just focus briefly on our vision, which is healthy people, healthy community, healthy economy. We believe that those things are totally linked together and cannot be separated. And then our mission, which is together with our partners, we empower and improve the health and economic vitality of individuals, organizations, and communities by catalyzing the power of collaboration. This is something we must work together on. Next slide. We recognize that there are many problems in healthcare delivery and that have to be solved so that we can improve health outcomes. And I'm not going to go through these, but we will provide the slides and you will have an opportunity later to look at what we think are some of the main challenges in healthcare delivery. Next slide, please. So we partner with those who get care, give care, and pay for care. And you know, guess what? That's everybody. Because if you're not a physician, if you're not a health system, if you're not a clinical expert or some other type of healthcare expert who would be giving care, or you're not an employer or an insurance company paying for care, you're still getting care. We all get care in some way, shape, or form. And so we really partner with everyone who has any opportunity to touch the healthcare sector. Next slide. And this one really brings it all together. Everybody in the process, everybody in the healthcare system has contributed to the problems. I know we can all step back and say, not me, but at some level we all have. And we totally and firmly believe that in order to make a difference, we all have to be involved, we all have to be engaged, and we all have to do our role. And so that's where this slide comes in. And I think it's, you know, it's kind of eye-opening. Like I said, you know, we always like to step back and think that I'm not part of the problem, but we all are at some level. So anyway, that's just a couple-minute background introduction to GTECH. I know I said it's probably 5 slides, but I went through them pretty fast. So now I am pleased to introduce our presenters, Dr. Saad from Patients First Medical Clinic. Dr. Saad was born and raised in Dearborn, Michigan. He has a passion for his local community and is committed to providing exceptional health care to his partners and patients. At his full-service practice, Dr. Saad offers primary care services and specializes in the treatment and management of addiction. Dr. Saad is a dual board-certified doctor specializing in internal medicine and addiction medicine. He worked as a general hospitalist for 2 years while preparing to open his primary practice in his hometown of Dearborn. He soon realized the need for primary care providers such as himself to help with the significant problem of opioid addiction within the community, and decided to focus his practice on the treatment of opiate and alcohol dependency. He is privileged to work with the peer recovery coaches provided by Hygira Health and GrowthWorks, as well as partnering with GTECH, the Drug Enforcement Administration, and the Michigan Department of Licensing and Regulation Affairs to improve provider education. Welcome, Dr. Saad. And then I will introduce George Long, and after that, I will let the two of them take over. George Long is the director for Dr. Saad's medical clinics and programs. George has a long history of medical practice administration, assessment and transformation, and medicated assisted treatment programs. In addition to developing increased access to medication strategies for patients with substance use disorder, George and Dr. Saad educate and share their experience and proven successes and processes with providers throughout the state of Michigan. So again, welcome Dr. Saad and George Long.
Thank you for having us. Thank you for giving us the opportunity to speak to a great audience. And the presentation that George and me put together hopefully will just shine a light to how we're providing MAT during this COVID outbreak. So I'll let George take over to start the presentation.
Okay. Thank you all for joining us. It's a tremendous privilege. I had a chance to look at the guest list of the folks who are going to be watching, and these are all very important institutions, companies, people that we've had a chance to work with in the past, or we're looking forward to working with in the future and sharing. And just we really appreciate you taking the time to out of your days to jump in here and maybe learn a couple things or even contribute, ask some good questions, and we'll have a good discussion or conversation as we go through this. The presentation is just a jumping off point. Some of the stuff you'll see is it's common sense, but as one of the first emergencies that has arisen since we started doing MAT over the last 10 years, we really started enacting and putting into place things that make sense and learning as we go. So we're always learning, we're always adjusting. And so if we look at the topics we're going to talk about today, some of this stuff is basic, but you have to start somewhere and you have to go from wondering to jumping out and doing the work. And that's how we keep people related to MAT treatment in treatment longer, because that's truly the litmus test or the yardstick for success is how long can we keep people in treatment. So if we're going to help them stay in treatment longer, no matter what it takes, doing something new, doing something outside our comfort zone is ultimately going to have a great improvement or outcome. So we're going to talk about prioritizing both the patient and the staff safety. We're going to talk about how we did telemedicine expansion in our practices, which we have one here in Dearborn, and we also have another one in Sterling Heights. Then we talk about the operational aspects of MAT treatment on-site and virtual concurrently with the same patients. We're going to blend their treatment. Additionally, we can't just forget about primary care when an emergency is happening. So we're going to talk about some of those considerations and how the patients have given us their reception to these changes. Of course, we also have to remember we have to keep the doors open. So we'll talk a little bit about reimbursement and it's not too tough, but just to know or understand that the payers have totally gotten behind this along with government, and we are getting reimbursement. We'll show you a few things to keep an eye on there. And then of course, re-engaging is super important for practices who maybe they shut down because they really didn't have the patient flow or reduced care. It's time to re-engage with our patients and get that flow coming again, getting the care again, so that we pick up where we left off pre-COVID or pre-emergency. So let's move on to the next one. All right, so first order of business is we had the onset of COVID was kind of slow onset. It wasn't one day the governor said go away and everybody's locked down at home. We had a little bit of news, we had a little bit of fear happening, lots of stuff happening on the television. And at some point we all kind of realized that this was going to become very localized and very serious to each of our own practices. And the governor gave us a stay-at-home order, so we had to get extremely proactive on protecting our patients as they would come here, and then protect our staff. If even one of our staff got sick, it would create exposure to the rest of the staff and patients. So we really need to make sure, obviously, that we have safety protocols in place that will help belay fear. And then one of the first things we noticed was purchasing PPE and sanitizer, and the like became very difficult through normal channels. So we got out in the supply chain and started networking with our community leaders. Dr. Saad is well networked, and was able to help us keep some of these supplies coming. And I've talked with other folks where, hey, we ran out of sanitizer, ran out of soap. Maybe Doc, you can chime in a little bit on your experience and how you helped us keep the flow going.
Yeah, absolutely. So PPE, sanitizer, soap was extremely important for us here in the clinic to continue the staff to feel comfortable coming in, to keep patients coming in and feeling safe when they get here. So we took all the necessary precautions. Any patient that was getting to the clinic, we were screening them before they were coming inside. If they had any viral symptoms, URI symptoms, at that point, we just kept them in their car and did a televisit. And we would screen them from the car. We even offered COVID testing at our clinic. We still do, but it's a drive-through testing system that we have. So we had patients stay in their car, they call in, and then we do the visit, and then we have a MA do the swab who's fully gowned in PPE equipment. She does the swab for the COVID, and then the patient continues the visit on the phone. So that's one thing we did, was we tried to keep the virus from coming into the clinic. We reached out to, I had somebody dedicated just to securing PPE. So he was online shopping so many different websites, even Amazon Business, local ACOs that were providing PPE for doctors, local hospital systems. We reached out everywhere. We gathered enough KN95 masks to get us through the first couple months, along with sanitizers. I even reached out to the local state rep that I work with, who was able to get some from Lansing for us. So he got a donation from Ford for the face shields, and then got some N95s, and was able to bring them over to the clinic that we were able to use as well. So, I kind of just went through my phone book, and anybody that I thought that could help with gathering PPE for us, I did that. And now we're in a comfortable setting, and we're able to go right on Amazon Business and order any type of masks or soap or sanitizer that we need, and we get it here within a week. So I think now we're past the acute phase where we're real worried about securing the masks and sanitizer and soap. So that's kind of how I was able to, get us through the first month and a half to make sure that we had enough PPE available here in the office for the employees and the patients. Next slide.
Oh, by the way, on that previous slide, there's a link to the website on CDC there where you can print out some of the different resources that you put up in your clinic so people know, hey, if I'm symptomatic, call the front desk, those sorts of things, and those are great posters. So on all of our slides, we'll have some links to some assistance, or we'll call it, the just really good, helpful information. And at the end of the presentation, a whole bunch of links to different sites that will fill in some of the gaps on details, or we'll just call it, very reliable public information that we relied on and is super helpful. So we're not just going to have a bunch of statements and chat, but there's places where you can go and get the good info. And also, if you have questions as we go through, make sure you put them through so Nikki can get us some of your questions, and we'll answer them as we go along. So one of the things that obviously we saw right after lockdown was the patients were hesitant to come to the clinic. Some were not knowing whether they could or couldn't go to their doctor's visits. Others were they're just afraid. There's plenty of fear. And we saw literally the day after the stay-at-home order went into effect that our clinic flow through virtually evaporated, and Dr. Saad was able to connect the dots very quickly and said, we need outreach. Outreach has been the #1 key. Communication and outreach is a way to initiate the telehealth expansion. We were able to proactively work with our front desk people, reaching out to our individual patients that had appointments that day or the coming days, educate them on what we were going to be doing, which is offering telehealth visits, and the why, which is super critical. It keeps the connection going. We're talking about continuity of care, but also, as we can see here, reduces the risk of transmission by keeping our potential carriers not traveling, not coming here. Or while they're traveling, they're going elsewhere while they're in the car. They're going to stop at the gas station, stop at the store. If you keep them at home and have a telehealth visit, it improves the opportunity to keep that transmission down and insulates that healthy population here by reducing their exposure to new people coming in the door. We also were able to manage treating patients with very little notice. If we saw that somebody hadn't come in, in a while, and they called in, we were able to get them on a telehealth visit immediately. That's part of our longtime mantra is if somebody calls in and says, I have a dependency issue, I have a treatment issue, it could be anything, we don't play around with making an appointment out in the future. We say, can you come today? Because if they're having a moment of need, we're going to be there for them. And that's how treatment starts, is when they have a moment of clarity, you have to get them started on the road to recovery, getting them assessed with MAT and getting them moving forward with momentum. So we keep that today type of mantra happening. So we're allowed to use almost any platform based on the stay-at-home order. CMS gave us that waiver, which is a link down at the bottom. But going forward, we want to use HIPAA compliant platforms like Zoom or GoToMeeting is a good face-to-face video, but you're going to have to still dovetail that into your EHR. There are other good platforms, eVisit, DoxyMe, et cetera, that are HIPAA compliant, and they're built around telehealth. So there's plenty of telehealth platforms for any of the practices that are currently not using it and want to use it. It's easy to stand up. We were looking at telehealth prior to this emergency, but it just gave us some comfort in knowing that we can have some of these interactions with patients and that they have a good, they have a good experience with it. So going forward, one of the reasons that we were doing telehealth was to triage patients who called in with telehealth or with, COVID-like symptoms. And Dr. Saad was explaining that he was able to keep them and the virus from coming into the clinic and that potential for spread. So once we were able to triage them over the phone, we could make a plan for the next step. So is that going to get a test going? Is it going to be send that patient directly to the ER? Triaging what's happening can help us as a primary care clinic reduce overutilization or overburden of the ERs. You may recall the ERs were slammed initially because people were going there symptomatic, but maybe they didn't necessarily have COVID or need to be using the hospital's resources. We were using our clinic as a setting for triaging pre-hospital. So if a patient was having symptoms, we could ascertain whether it was COVID related or something along the lines of we had lots of sinusitis or flu itself. As we were doing testing and doing assessment there, so we were able to get those people treated and stay at home rather than having them on their own, just going straight to the hospital. So staying open is important for primary care because it helps manage a lot of patients and their chief complaints and keeping them from going to the hospitals. So we think that the future of telemedicine here is going to help us better manage the future of managing influenza. And it's not our last emergency, we're going to have others, but if we're using sanitizing and clean procedures here in the office, more telemedicine, we think that the opportunity for flu, which happens every season, may have less opportunity for transmission and then less opportunity for complications and deaths going forward. So that is one of the things that we definitely feel we're going to be able to contribute. And health-wise, healthcare system-wise, if other practices are doing the same, even if they're not adopting telemedicine, if they're adopting sanitizing based on post-COVID, they should be able to reduce that, the influenza complications. So there's a link at the bottom there for what you can do right now related to COVID, but we're going to be, we're transferring out of COVID times, but it's not our last emergency by a long shot. So if we have cut our teeth on telehealth, we've cut our teeth on getting better cleaning and sanitizing going, we'll be ready the next time things go around. So now it's time to move to the next one. And this is where Dr. Saad is going to really shine. All right, so like I said before, our proactive outreach to connect to those patients and assure them they get to stay in care was huge. We want to treat new patients always initially on site because it is still MAT, and many times we're prescribing a medication, buprenorphine. We have to have a real, solid foundation for starting that relationship. Other patients, they're on previously on Vivitrol, which we're really tremendous fans of, and we do a lot of Vivitrol treatments. Some of those patients were happy to keep coming and keep up with their injections. Others were not able to keep coming out of fear and whatnot, so we're able to use the telehealth to reassure them and stay on treatment, but we would prescribe them, medications for that. So, Doc, maybe you can chime in here and talk about kind of.
So yeah, absolutely. So the transition, MAT is a tricky subject to be treating through telehealth. You want to make sure you're touching your patients frequently, seeing them frequently, monitoring their urine drug screens, discussing how their rehab and recovery is going, because at any moment, these patients can relapse, and you want to be able to see them and see where they are in their life. So when we went to switch into the COVID type of setting in our clinic, we sat down, me and George, and tried to figure out how can we continue to talk to our patients weekly, bi-weekly, try to continue guiding them and making sure that they're in recovery, they're not relapsing, they're not, at this point, going back to the drug that they were abusing, and also continue to provide the MAT to them that we were providing previously. So we made a few stipulations and guidelines. Our staff instituted them. The patients quickly adjusted. So for patients that I've been seeing for years, it was easy to get them to switch to telehealth, make them feel safe, continue their medication, and then bring them in as needed to do the urine drug screening that was required. So I was able to do that through COVID for the first couple months. And now the patients on their own are saying, you know what, I want to come back into the clinic. I want to be seen live. I feel safer. And we had no hiccups during these 3 months for their MAT and their recovery and their treatment. Now, a lot of new patients started popping into the clinic around March, April, and I attribute it to, because the majority of them, when I would take a history and physical, it was their physician that they were seeing previously just closed down, or they didn't know how to get into contact with them. So a lot of these patients were in recovery, doing well on some type of MAT, whether it was buprenorphine or Vivitrol, but they didn't know where to go anymore once March came and April came, because the physician they were seeing closed down, or they didn't have any contact to them. So those patients, I seen them in person, but I also was a little more flexible transitioning them to telehealth, because their maps and their history showed that they were doing good, they were in recovery, their urine drug screens were proving that they were taking their medication and doing well. And I was able to transition them so that they didn't relapse during the COVID season because their initial doctor stopped seeing them. So we had some of those new patients as well. And then we had some people who weren't following a doctor, who were doing drugs or, you know, opioids, and it spiked up because of COVID. They lost their jobs, they were under more stress. Those patients I would bring into the clinic, see them weekly, have them connect to our recovery coach. So we have a peer recovery coach in the clinic, but once COVID started, she transitioned to doing it remotely. So she would do televisits for recovery. And we had our recovery coach talking to these newer patients twice a week, getting them in if they needed to more type of therapy. And then I would see them weekly on a televisit approach, and then bi-weekly in person. So they would come in here every 14 days. We would monitor their urines. And then every week we would do a televisit. So they were getting seen by me 4 times a month and by our peer recovery coach once a week as well. So I think that transition allowed for a lot of people to get help that might have not been able to get help if telehealth wasn't available and if we didn't institute what we had set up in our clinic. So you can add anything else you want, George, to what we were doing here.
I think having the partnership, which is key to how, you know, the collaboration is key to how GTECH operates, is one of our really core philosophies, as well as, you know, we partner and collaborate with others that can add value to us. So the peer recovery coach through GrowthWorks and Hygera Health has just been a tremendous add-on, because patients are able to go straight from seeing the physician to seeing somebody that's going to help them connect to resources out in the community and get more engaged in their recovery. We've seen a lot better long-term successes, and we have so many other great partnerships that we work with through Detroit Wayne Mental Health, through the counties, through the payers, through you know, some of the you know, the excellent pharma companies. So those folks all we all work together, and so any hospital system or clinical team that's watching right now, you're not on an island. You need to connect with as many as you can. That's the number one best thing you can do is work together, team up. All right, let's move on. Well, we can't forget about the reason that you know, many of the clinics are open in the first place is their primary care, and we have a lot of patients that we saw, you know, we've all seen on the news where primary care kind of took a back seat, and some of those patients had ongoing care issues that just hit the ground and sometimes developed into reasons that they wouldn't go to the ER. So we didn't forget about primary care and just shut our doors to primary care, but some of the non-emergent preventative stuff, we delayed those visits for the time being, but we did, of course, continue care for all the patients we had that had chronic conditions. So we wanted to make sure that those people that we had done labs on or we were doing labs on, and we wanted to follow up with the care plan, make sure medications were prescribed, or renewals of medications, we would have those visits via telehealth and keep their care going forward, especially patients that have chronic issues of hypertension or diabetes ad infinitum. They're just as important as MAT to keep the momentum going, to keep the duration of care happening. If you slip up for a month, any of those can become a very bad complication. So we want to make sure that we keep those going through telehealth, which would reduce those folks' exposure to COVID, especially if they had chronic conditions. They're more at risk for a bad outcome, more at risk for a complication if they come to our clinic and inadvertently get exposed to somebody who's ill. So for patients that did have other acute conditions that warranted in-office assessment, we'd have those folks come in, and we had several treatment rooms that were for sick patients only. And even though every room got a lot of scrubbing and a lot of cleaning, we were able to really focus on keeping the sick patients in one section of the office, and that helped keep things contained. Anything to add there, Doc?
No, I think you hit the main points. The telehealth really, allowed for some of the patients with other chronic conditions to continue treatment for them and management of them while they're at home, safe, away from any exposure, and then they were continuing their medications or what was necessary to keep them healthy during these last few months. So I think you had more, the main parts that we wanted to try to bring across.
All right, let's keep going. This is all you, Doc.
Yeah, absolutely. So the patients, initially they were a little hesitant, like, how are we going to do this? A lot of patients I started calling the day of their appointments to let them know that they were going to continue treatment. So we would call patients and let them know we're still open. We're going to do a televisit. We're going to continue your care. You're going to stay safe. You're going to continue your treatment, and you're not going to be exposed. And when we explained it that simple, patients loved it. And they were so happy that they can get to see their doctor, get to see their recovery coach, continue the treatment. For anybody who takes care of a patient on MAT, they know how important it is for these patients to be seen and to continue their treatment, especially patients on buprenorphine. So they have an anxiety that their doctor's going to shut down, or they're not going to see their physician, or their pharmacy's not going to fill their medicine. There's so many times where patients will say that to us, and that kind of feeds into their brain for relapsing, is just that increased anxiety of, oh my God, am I going to continue the buprenorphine? Am I going to go through a withdrawal if I can't get my medication? So we made an effort for all our patients that we were following. Let's reach out to them. Let's call them. Let's explain to them that we're going to continue treatment. We're not going to close down any days, and they're going to do okay, and we're going to get through this pandemic together. So extremely positive reaction from these patients. It was very convenient, very simple. We connected them with also some pharmacies in their area that were still open. That way they were able to go pick up their medications, no issues. And a lot of them really enjoyed that they didn't have to drive here as often before the pandemic that they were doing. They were able to do this from their convenience of their home. A lot of this patient population don't have cars, they don't have transportation. Sometimes their health insurances are the ones that set up the transportation. They were able to avoid all of that over the last few months, which really helped in them staying in recovery and doing better, because we removed the anxiety and the stress of what's going on with the pandemic and how they're going to continue their treatment. So we really hope that we can institute telemedicine to become more a permanent part of our program going forward, and allowing people to continue to have accessibility, and for it to be convenient, simple, and continue monitoring our patients frequently with the telemedicine application that we've added to our clinic. So it was overall an extremely positive reaction the last 3 months with the telemedicine and the COVID that we've been treating. All right, George, you can take over if you want.
All right, let's move on. There we go, Nikki. So what's on many people's minds was reimbursement, even on ours. At the outset, you know, we were reassured by the governor and by Medicare and others that reimbursement was going to be, you know, held, and make sure that it was going to be offered for all plans and all participants, et cetera. But, you know, no road is ever paved with gold. And this road is paved with learning, a little bit of learning, but we had great experiences with our in-house billing folks and our sourced billing experts, and we worked with them to understand the differences between the different payer models. Some payers had a different site called out, so there's 2 different sites that we're using, which is 02, which is usually a telemedicine site, origination site, and 11, which is an office-based site. And then the modifier can either be GT or 95. So these 2 groups of add-on codes have to do with the individual payers' policies. And so since there are many payers, you know, we can't say this company pays with this group of coding and whatnot, but those are the site-specific and modifier-specific codes that need to be used. And below there are some links for guidance from Blue Cross and from United Healthcare. And those are kind of our two big folks. Medicare and Medicaid, of course, has their own coding sequence, which is pretty much the same as UHC. So we'll just kind of throw that out there. So the key here was to get the mindset of the providers to make sure that they're coding correctly while they're charting. So they're doing a good job of charting, and they're going to do this whatever E&M code they're going to use based on the time and complexity. So 99211s through 215s for those folks. And there's another code, which is the Q3014, which is a telehealth facility fee, which does usually apply. So some payers pay for that facility fee, some payers do not. So we just would see that certain payers were paying something on the order of about $20, which helped offset our infrastructure and other costs. So that would be those 2 codes for the CPT side of it were married up with our sites code and our modifier, and we were seeing that we were getting reimbursed. So if we had any challenges, you know, not covered, then we would go back and look at how did we do it, and go the other direction and really research into that payer and say, what did we miss there? But really, if you're just doing the CPT codes with the site and the modifier per that payer, you're rock solid. So if you guys you know, need any help on this front, you can go to the links. You can always shoot me an email and I get you more specific information there. One more page. So one of the most important things that we want to bring for the entire program here is that for practices or for providers that felt like it was important to close your practice or reduce or whatever, it's time to re-engage. Things have lightened up, and people are done being locked up, cooped up at home. They're happy to get back out in the world. You know, everybody wants to get back out there. So re-engaging with your patients, this is a great time to do it. There's stimulus money available, and for everybody who's a provider, whether you're hospitals or clinics, you should have gotten you know, stimulus checks already, which should help. They didn't really send you a notice. You should have just looked in your checking account and it would have just miraculously appeared under HHS stimulus. There's also, you know, SBA grants and loans that were dispersed, but there's more in the pipeline. So there's an SBA link on the next page where you can go there and look at some different opportunities from the government to get some finance to help you get reconnected with your base. And so, you know, you want to reopen with your precautions that we talked about. Those are very common sense and at a pace that works for you and your staff. As number 4 points out, there's a lot of need for care. It's pent up, and people that have regular ongoing care that they've been afraid to go see their physician, afraid to get out, afraid to go to the hospital, afraid to go to the clinic or urgent care. It's time to, you know, get that flow back into your clinic. You can go through, you know, if you feel stalled out, go back through your patient list and proactively do some outreach and invite them back in, and, you know, tell them, hey, we've got this under control, and we're going to be very safe and care minded. And, you know, you have to, you know, bite at it one nibble at a time, and you'll see that things are going to, you know, get back going. So for people that are on MAT and maybe they drifted away, it's a good way to get them re-engaged. So go through your MAT list, your patient list, call every last one of them. And if they've caught on with another clinic, that's great. As long as they're getting care, that's what counts. And, you know, if they kind of slipped beneath the cracks and they may have relapsed, absolutely, this is a very scary time. You know, they're sensitive people, and relapse happens. So that's okay. You know, get them back in, get them started fresh again, get them re-engaged, and, you know, get care going again. Between everybody I saw on the list, you know, we've got providers, we've got payers, we have health systems. Everybody needs to work together on getting everybody re-engaged if they haven't already been, you know, working on getting the MAT continuity happening. Doc, what do you think?
Absolutely, especially right now with my history working with addiction patients over the last few years. Just seeing anytime there's instability is when these patients usually the mechanism of addiction goes into relapse mode. So their brain will tend to divert back to relapse, and it'll start look for some type of stimulant or some type of drug that'll help make them feel good again. So during this COVID pandemic, we're seeing a lot of people stuck at home, jobs are being lost, there's a lot more stress going around. This is what worries me, is we're brewing a pandemic that's going to come from the relapse and the addiction and the drug use. So we really need to, as you know, providers, practitioners, hospital systems, re-engage our patients that were doing well or that were seeking treatment that have fallen off over the last few months. Check up on them, try to get them back into an MAT program, you know, try to get them the help that they need, because, you know, this is what will also cause an increase. We've been doing a good job over the last few years. You know, the overdose deaths have been coming down over the last few years. We're increasing the MAT treatment. We really need to prevent a hiccup in the road by re-engaging our patients, try to let people know that there is help out there, and continuing MAT treatment and increasing the accessibility during this pandemic. So I completely agree with what you've just said, George.
All right, super. Nikki, next slide. All right, so I promised you some resources. Some of this stuff is, you know, kind of obvious, but you have to start with all your basic gospel go-to links that give you a starting point of all the information. So each county has their own COVID-related link. SBA for getting support medically or for medical practices is huge there. And then the CDC guidelines and criteria are huge. So in the future, we're going to have other emergencies. So these same links will be modified ever so slightly, but these institutions are the place to go to get our immediate help. And if we get some guidance from CDC, you know, which is the medical related information, the state and counties related to our political and local resources, and then SBA for the government support. This is going to happen with almost any problems that come up in the future. You know, any other, you know, not just a pandemic, but any sort of stated emergency. You know, we're going to want to use these resources. So having these in your back pocket going forward, or just go there and then surf through here, and these will branch down into more and more and more resources available based on what your individual practice needs. Does anybody have any questions? Might want to just start shooting them through. Let's see.
You know what? I just found out I was muted, so I'm sorry. Sorry. This is Kate. So okay. There are a few questions that have come in that I wanted to start off with, and then we'll open it up for other questions. One of the things that he talked about, the telehealth and, you know, what the future of that might look like. Well, how do you respond to patients who perhaps don't have access to the internet, or don't have you know, a source or a tool that they could use to connect on a telehealth basis? Is that an issue that you've been seeing or witnessing? Or maybe they get a surprise billing from their health plan and they can't afford it.
That's a super common one, the surprise billing. We try to remind folks, don't worry about the bill, just come and bring the bill with you and we'll work to sort it out. You know, more often than not, it's something that we can work through with copay assistance, like with Vivitrol. They have a great copay assistance plan. And if it has to do with, they get a bill from a provider or a hospital, we're going to work with them and show them how to negotiate it or get that put on the back burner, because shorting your MAT progress over a financial issue is just absolutely not part of the program. But sometimes patients will reappear out of the past and say, well, I didn't come because my insurance went away. And we really try to hammer that home ahead of time. Don't stop coming just because your insurance goes away. We're able to help folks. We sit them down at a computer, and if their insurance has gone away, chances are they may qualify for state, you know, Medicaid. So we get them on the Michigan website, you know, which is newmibridges.mi.gov, and get them applied for Medicaid so they can get some coverage going again. That's an #1 thing for us.
Great, thank you. So you deal with mostly substance use disorders and alcohol issues. Are there other kinds of addictions that have similar maybe root causes? You know, like maybe eating addictions or shopping or so forth addictions that have, you know, similar root causes, and where would we direct people for that kind of care?
So I can answer this one, George. In terms of addiction, the mechanism in the brain is similar across the board. Now, different drugs act on different receptors, but the mechanism of addiction and relapse and recovery is the same area in the brain. And as a board certified addiction doctor, you know, we should be able to handle the majority of addictions people can have. But for eating disorders specifically, I refer mine to a psychiatrist.
Okay.
Yeah, because there's usually a co-occurring psych disorder with eating disorders that I like a psychiatrist to be involved in. And those are the most difficult addictions that I face. But in terms of drug addictions, regardless of the drug, an addiction doctor should take care of those problems.
Okay, thank you. Given that many people are reluctant to attend rehab right now, do your clinics prescribe medication for individuals to safely detox from alcohol on an outpatient basis?
Great question. So in terms of medications to help detox, it's a benzo that would help you detox. For alcohol withdrawal, you want to prevent an alcohol withdrawal seizure, which will kill you. If you have a seizure and not in a good setting, you could die. So an alcohol withdrawal is an extremely tricky and critical situation to handle. So you prefer somebody, if they're a heavy drinker with a history of seizures, to be in a controlled setting. But with people reluctant going to rehabs or hospitals, I have had patients where I would give them some benzo and explain to them, you know, if you have jitteriness, you start having symptoms of alcohol withdrawal, you can use this medication to help with that. But if it, you know, I really prefer you going to a rehab or a hospital if it's something that you cannot control, or if it's something that you have a history of, I definitely want you to be admitted to go through the withdrawal initially.
Yeah, that's interesting. I recall reading many, many years ago that people could die from alcohol withdrawal, but I forgot about that. So thanks for bringing that back up.
You're welcome.
Question, have you researched or surveyed changes in substance use and coping behaviors during the pandemic?
So I haven't researched anything, but like I said, I can talk about my own personal experiences with my patients. Some patients of mine that have relapsed or left the clinic, the way they cope is they go back to their drug that helped them feel good or stimulated them previously when they felt good. So that's kind of how they're coping. But the ones that are continuing treatment, the way they're coping the best is with our recovery coach. That's for one. They all are reaching out more. I've had a couple discussions with our recovery coach who said she's noticing some patients calling her more often. So definitely therapy, recovery coach is another way they're coping. You know, that's from the short amount of time that I've had with my patients to see how they're coping through this pandemic.
Okay. There's some comments here on the chat box from people about, you know, the increases in fentanyl, because it's been a little harder to get some of these drugs like heroin on the street right now, but they're now using more and more fentanyl. Can you comment on that?
Yeah, absolutely. I was just making a comment that the streets, as Mr. Scott had said it, you know, patients are complaining that it's getting dry on the streets, which is absolutely true. It's harder to find Suboxone on the street. It's harder to find painkillers on the street or heroin on the street. A lot of the dope dealers, you know, are on the street. What we're noticing with our newer patients or patients that relapse is their urine is coming up with synthetic fentanyl. And that's really what's dangerous and can cause overdose and death, is the synthetic fentanyl. And I'm starting to see that a lot of patients that used to relapse on painkillers, or they would have, you know, heroin in their urine or even benzos, now they're coming up with fentanyl when they're relapsing. So they're starting to get a little more desperate as this, you know, it's harder to get certain drugs on the streets.
That's got to be a very difficult place to be for people. What kind of experiences and outcomes with prescribing oral naltrexone in place of Vivitrol injections for alcohol or opiate dependency have you seen?
So we, as George had said earlier, we really are a huge fan of the injectable naltrexone extended release in our clinic. And we did see a drop off in who was continuously coming in. So we had about a 35 to 40% drop off in terms of the patients coming in monthly for their injectable naltrexone. What we noticed is some of the patients, we would do televisits and we put them on the oral naltrexone. They do well on it when they're compliant. And that's the biggest issue, is if you have somebody who is an opioid addict and you put them on oral naltrexone, they'll stop their naltrexone if they want, and then they'll relapse, over the weekend. And that's been a big issue. But if it's somebody who's willing to stay compliant, it works real well as well. You can use the oral naltrexone. For those patients, instead of doing the once a month visit, I actually do a bi-weekly televisit, and I call them, see how they're doing with the oral tablets. Just make sure that they're trying to stay on, stay compliant, stay in recovery. And I've been using the oral tablets, more for the patients that are coming for their injectable.
Great. So another question is on increased expenses due to masks and sanitizing. And if you or if you know of anybody who's keeping track of those increased expenses, and what about reimbursement for those types of costs?
Yeah, so that's a George question.
Well, in general, this stuff is not very cost prohibitive. In the overall sense of it, we should be we should have sanitizer. We already had sanitizing stations in the practice, and gloves and masks. It was a matter of having a lot of that based on the amount that we were going to go through. But since we also had a blend of televisits versus on-site visits, we didn't have quite as many people coming through the office, so they weren't going to be taking they weren't going to be taking masks, etc. However, it was definitely, we needed to buy a lot more than we ever had it previously. So initially, we were able to get our hands on some through the normal channels, but as we talked about, that market dried up, and then we ended up having, we had to get creative. So one of the things we use is one of Dr. Saad mentioned, one of our guys. So he's an intern that he's younger, he's tech savvy, very comfortable shopping on the internet, and was able to identify, back doors to get into, different places to make some purchases, but still got to be ever mindful of getting gouged. We saw plenty of opportunities to purchase PPE, but it was so expensive that we opted out of that. So, that transaction. So, if you're sitting there and somebody's trying to hit you up for, $10 or $20 for this small little thing of sanitizer that isn't going to last one day, even though it's available, you're not going to enter into that kind of an agreement. So we really had to shop hard and be choosy. And like Dr. Saad said, he networked hard locally. So between all of that, we were able to get what we needed to get supplied. But it's a lesson learned. Now we should have more stocks on hand going forward, because it doesn't cost that much, and you can buy all the various items you need and stock up without too much expense.
Well, I think that's valuable advice for a lot of people who are on the call who, haven't maybe had to purchase those things yet, but are going to need to. So appreciate that. Unfortunately, we're out of time. It's 2:30. So if you had other questions that we weren't able to get to, please send them to us, and we'll do our best to get them answered and send the answers out to everyone who's been on the call.
Yeah.
We appreciate your, pardon me?
That's great.
Okay.
Nikki, if you go to the next slide. If we're able to click the next slide, it's got our email addresses. If you have any need for, consultation, advice, you need to get some clarification, you can shoot us an email, just george@saadmd.com, and that will get you through. So if you have any questions or you need anything, just let us, be a resource for you. Everybody on the call, we really appreciate you taking the time to out of your day to come, and we're thrilled that we're able to share a little bit. And we look forward to partnering with all of you. Our job is really about getting the message out, or the ability to touch and help more folks.
Awesome. Thank you again from GTECH. We will, we're going to provide this, the presentation to everyone as well.
Super.
Great.
Thanks for having us.
Stay safe. Yeah, thank you so much. We appreciate your efforts on this. And I hope everyone stays safe and has a great weekend. Take care.
Same to you. Okay, bye now.
Thanks, George. Hello.
Hey.
My screen is like blinking at the very end. It started flashing, and so I couldn't go.
Flashy thing.
Sorry about that.
No, we're good. Hopefully, it was helpful, and we had a good time.
No, that was great. Thank you. We appreciate it.
We were learning.
All right, I'm going to sign us off here.